has been undergoing substantial transformation since its first edition. I hope one of the important transformations for the next edition will be there will be more of humanities and social science people, NGOs, and those who can contribute to the awareness and attitudinal issues of mHealth. Thank you very much.
Thank you, Dr. Lourdeswamy, for keeping up to time. While Professor Arun Roy is getting his slides ready, just to data, and Professor Arun Roy and his team did the very difficult and onerous task of analyzing the data.
Well, thank you, Dr. Ganapathy. I'm back again, but hopefully for the last time. So we have this project is done along with Dr. Ganapathy and my postdoctoral student, Shishi Lee. The health divide basics, I'll just rush through them. We have heard plenty about the statistics about the health divide in India in terms of where things stand, so I will not rehash those statistics. Mobile technologies as a potential source comes in quite interestingly. I thought I must share at this forum something I read just a couple days ago. The United Nations has declared that internet access is a human right. I just asked us to pause and think about that, because as we think about two fundamental human rights, I would say health and now, interestingly, internet access come together, perhaps in a pretty cohesive manner. I just leave that for us to reflect on. When you look at mHealth, of course, it could be used for a variety of things, but not just diagnosis. If you take diagnosis out of the picture, it could be used for health advice, exchanging clinical information, monitoring and compliance types of solutions. And for a variety of treatments, diabetes, prenatal care, maternal health, etc., and you've heard plenty about that. In terms of our study, the sites and data collection, Dr. Ganapathy mentioned these two camps that were held in Tamil Nadu and by Apollo Hospitals and ATNF. We developed the questionnaire collaboratively, and then Apollo Hospitals Education and Research Foundation went through the outstanding task of collecting the data at these camps from the citizens who attended. And we were fortunate to actually come up with a pretty fantastic sample with over 2,000 people, about 1,123 from one of the camps and about 1,000 from the second camp. The demographics are as follows. You had age ranges from 20 to 70, 56% female, 44% male, 83% married. And if you look at the educational statistics, this maps in pretty, as you would expect, with lower levels of education, farmer-based population, and over 90% had monthly incomes less than 7,500 INR. If you look at computer, internet, and mobile phone access, here are some interesting statistics, perhaps again sobering in some ways. 1% report having a computer and internet at home. Hardly anybody with internet access. But the kiosk aspect is interesting. You had 28% that reported being able to use a computer or kiosk that was made accessible to them at their villages. In terms of mobile access, while we talk about everybody having mobile phones, of course, we notice that the proportion that don't have it in rural parts of the country, especially amongst the most underprivileged, is likely going to be the greatest. So what we found here was that 35% shared a phone, 26% owned a phone, and 39% actually had no access to a mobile phone. So while we talk about the A's and the notion of access, it's important for us to also recognize that sharing is one way that people do get access, with different implications on how that is managed. The mobile phone service usage, interesting aspect out here, phone calls and text messages. Actually, what we found there was the people that shared reported that they were using the phone more for these purposes, but when you look at value-added services, that's where the people that owned reported greater use for value-added services. What we found very striking, and Dr. Ganapathy and I have spent quite some time talking about this issue, is that 440 people, 20%, reported they had used the mobile phone for obtaining some form of health-related information. Suggests promise. The willingness to use mHealth services for the two camps combined, if you look at it initially, the numbers are depressed, meaning they're low. They don't crack over neutral if you look at it on a mean value aspect. But if you drill in further into the data, what we found was 1,000 people, almost 50%, slightly lower than 50%, had neutral or favorable attitudes. That's pretty promising, that you got 50% of the people with neutral or favorable attitudes. Now, one of the questions we wanted to ask was whether there was some price sensitivity to this willingness to use something, even at a marginal cost of offering a service. And as you would expect, there is high price sensitivity. You see a dive of about 50% for each 100 rupee margin that you're added on a per year basis. So you have about 24% that say that they're still favorable, meaning 3 or above, if you charge them 100 rupees per year. And then you have about 12% that are still favorable if you charge them 200 rupees or above per year. Willingness, I'll skip the cross-camp comparison. There are some interesting differences between the camps, but I'll skip that in the interest of time. But the Sri Rangam camp reported slightly higher willingness to use these services. So I'll just go over this rapidly. I'll move to what I think is the really interesting part here. You would expect, and we found it, that if indeed people own phones, you're going to see much more favorable response than those that shared phones versus those that did not own a phone. So this is validating the hypothesis of does access lead to more favorable attitudes or intentions? The answer is yes. And we found that at all price points. Yes, there's a systematic price elasticity that you observe pretty steep, but the access does matter. But what's more interesting to me and to us in this is that looking at access independent of the health condition of the patient or the citizen is an overly simplified issue. We're oversimplifying the problem. What we noticed here was that as the health issues of the patient were more complicated, whether they had access, even when they had access to a phone, their attitudes towards using it for health-related purposes declined. So the key message here, both from the United States study and from a study in rural Tamil Nadu, is the same. Access matters, but it's going to be much more effective with people who are not very sick. It's going to be effective with people that feel they are vulnerable, but not very sick. So if you think about the issue of digital divide and health divide, I started with this idea of the United Nations declaring internet access as a human right, and health, we would all, I believe, in this audience agree, is a human right. We have an interesting challenge ahead of us in that we have the advantage, even within, relatively advantaged, I would say, within rural India, those that own phones and those that are more healthy. And I think there we may have a way to get to them. This one is still a very hard question. And I think we need to think together on creative ways to address it. Thank you very much. Again, I would like to acknowledge the Apollo Health Research Education Foundation for all their support. Wonderful audience. Thank you very much.
Thank you, Dr. Arun Rai. As usual, I'm trying to have the last word. In the next 600 seconds, I will try to show you how very soon, sooner than later, we are going to have a doctor in your pocket, a hospital in your pocket, and a laboratory in your pocket. We should get away from the idea that the hospital is the be-all and end-all of treatment or the physician's clinic. I love this phrase DIY, do it yourself. And we will see how the phone can be used both for as a software, as a hardware, and various other mechanisms. And Dr. Arun Rai has shown very clearly how even in rural India, 61% have access to mobile phones. Now, a killer application, it's not a pun, but mobile health can certainly be a killer application. Today, mHealth is conspicuous, not only in India, but in many other countries by its absence. Indians are prepared to spend 5% of their rural income to watch Tendulkar hit a 4 or Amitabh Bachchan on a M-entertainment, M-banking, M-commerce, M-governance. All this have become a reality, whereas unfortunately M-health is far away from being a reality. And what is the world happening? In the world, more and more Cisco and other companies predict that almost 75% of your video communications will be through wireless technology. Qualcomm has bet a major part of its resources on the grounds that the whole world is going to become wireless. And I remember several years ago when I could not even get an appointment to see the secretary of a CEO of a mobile network company. Today, they are after us because purely from an ROI perspective, they have realized that an MVAS or a mobile value-added service, healthcare can certainly be top of the list. You are no longer going to make money out of phone calls by voice. In fact, Dr. Raghavan, who spoke to us yesterday, predicts that in a few years from now, voice calls will be totally free and we'll only be charging video calls. Ladies and gentlemen, we have just 20 million broadband connections. I was a telemedicine enthusiast to start with. Now I'm a mobile phone enthusiast for the simple reason that we are never ever going to bridge the urban-rural health divide using broadband, internet, NKN or not. On the other hand, we have 920 million mobile phones, and the government of India has put in a document that by 2020, they want every single citizen of India to own a mobile phone. May not happen in 2020, but certainly by 2030. So let's look into what exactly is going to happen. Now, I am now giving you some statistics not of the United States, but of emerging markets. 43% of players in emerging markets pay or plan to pay for telephone consultations. This is a study from PricewaterhouseCoopers. 44% of physicians, this is interesting, are worried that mHealth will make patients too dependent, and probably many of us will become members of an endangered species. Imagine how I become redundant, unnecessary, because everything is available on a mobile phone. 20% of patients in emerging countries, again Pricewaterhouse, would pay more than 250 rupees annually for mHealth service. Something very similar to what Dr. Arun Rai has demonstrated in rural Tamil Nadu. 61% of surveyed patients in emerging markets were aware